All right, we're going to go ahead and get started. Welcome, everybody, to our monthly Climate and Health webinar series as part of the Society of Academic Emergency Medicine, Wilderness Medicine, and Climate Change and Health interest groups. I have the privilege of introducing our speaker this month, Dr. Jonathan Slutzman, and I will read his bio here. Dr. Jonathan Slutzman is an instructor in emergency medicine at Massachusetts General Hospital and Harvard Medical School. He holds a bachelor's in civil and environmental engineering from Princeton University, an intern engineer certificate from the state of New York, and a medical degree with distinction in disaster medicine from the Albert Einstein College of Medicine. Prior to a career in medicine, Dr. Slutzman was a consulting environmental engineer, completing projects in a variety of areas within environmental, health, and safety assessment. These included industrial facility audits, commercial and industrial site assessments, environmental life cycle impact assessments, and disaster management exercises. He has completed work on medicine and nuclear war, suburban flood hydrology, healthcare cost modeling, and environmental life cycle assessment of healthcare processes. His academic focus is on the costs, both financial and environmental, of healthcare. He is a founding member and chair of the Massachusetts General Brigham Clinician Sustainability Group, a past chair of our Society for Academic Emergency Medicine Climate Change and Health Interest Group, as well as on the advisory committee of the Healthcare Without Harm Physician Network. So without further ado, he has been a mentor for many students and climate advocate without a doubt. So Dr. Slutzman, thank you so much for coming in to talk to us tonight.
Thank you, Caitlin. It's really a pleasure, and I see we're not the largest group, so if people have questions or want to interrupt or aren't sure about something that I said, please feel free to ask, and we can kind of take side tracks as people are interested, so we can really make this as meaningful for everyone as possible. As Caitlin said, I'm at Mass General and Harvard with additional associate appointments and having to do entirely with environmental stewardship at the health system level. So we're going to talk today about environmentally responsible healthcare, both a little bit about the impacts of healthcare so that we can set the groundwork, and then tools for how we can study and then maybe even move the needle a little bit on how we're doing in our environmental performance. I do have one disclosure that I have received travel funding from 3M for some work, which has nothing to do with anything that we'll be talking about today. So I'm starting from the outset that obviously if you're in a webinar from the Climate Change and Interest Group and the Wilderness Medicine Group, that you are already in the large chunk of people who are activated and care about our environmental performance and the climate crisis. So some of this might be a little bit of a review, but that's basically the premise from which we're working. So let's think about healthcare. We know that climate change is real. We know that our environment is quite a bit polluted and it's affecting human health. But really, I'm a doctor and I take care of patients. What does that have to do with it? And how can I really think about what I'm doing as being bad? I'm healing people. I'm saving their lives. And the reality is that healthcare is a really big contributor to our pollution problem. Let's look first at energy intensity. Healthcare is highly energy intensive. It is routinely the second most energy intensive commercial type building in the United States. You can see it's second only to food service on this chart that's put out by the US Energy Information Administration every few years. And then to make it even better, actually just this morning, I did a walking tour of the MGH commercial kitchen, which is quite impressive in what they do. So not only are we a healthcare institution, but at least at MGH, we are the busiest commercial kitchen in the Commonwealth of Massachusetts, producing 30,000 meals a day. So we are both healthcare and food service. So if there was any doubt about how energy intensive we are clearly at the top. Outpatient healthcare is not quite as energy intensive as inpatient healthcare, not surprising. It's not operating 24 hours a day. It doesn't necessarily have ORs that are a big energy draw, but it's still quite a bit higher than plenty of other things that we see. It's not so surprising that healthcare is a big impact. If you look at it economy-wide, the United States spends about 18% of its gross domestic product on healthcare. So you would expect us to be pretty large in a footprint, but remember, this is intensity that we're looking at. This is energy use per square foot. So so it's not an aggregate that we're so intensive. It's that we just are. We generate a lot of emissions. So let's look at our greenhouse gas emissions. These are, I want to say, from 2015, might be 2013. The numbers don't change a whole lot year to year. And it's the fraction of greenhouse gas emissions from each country on the planet. By far, China is the largest. They also have the most people. But the United States comes in a reasonably close second, followed by India. And if you were to look at these countries and just consider US healthcare, so healthcare services from the United States, and our greenhouse gas emissions, were pretty high. So we would be the 13th largest country in the world when measured by greenhouse gas emissions, just US healthcare. That's more than the United Kingdom, for instance, or Australia. These are, sizable countries with varied economies, and healthcare by itself in the United States is emitting more than that. So we are a big deal. If you look globally, net greenhouse gas emissions, healthcare is responsible for about 4.5%. In the United States, it's closer to about 10% of our emissions are from healthcare. So we have room to improve, especially if we want to say that others should clean up their act too. I like to say you should clean your own house before you start criticizing how messy someone else's house is. So what's the significance of this? And the significance is that we hurt people. So I started by saying that we're in the business of helping people. We heal people, we save their lives routinely, day in, day out, but it comes with a cost. And in the last, we'll say 15, 20 years, we've really recognized more and more the financial cost of the care we provide and how financially it's not particularly sustainable, but it's also environmentally costly. And those emissions, upstream and downstream, have important effects on our patients' health. Here we have data from Eckelman and Sherman's study of the total environmental impacts of the US healthcare system. That's where the 9.8% of greenhouse gas emissions number comes from. And here we have the 9 different impact categories on the left. Let's see if I can, here's my laser pointer. You have different impact categories: global warming, acidification potential, particulate matter, ozone depletion potential, photochemical ozone, ecotoxicity potential, human health, cancerous and non-cancerous effects, and eutrophication. So in each of these categories, we emit pollutants that have an impact, and then we can translate that to DALYs. And some of you might be familiar with DALYs, some might not. It's an economic measure. It stands for Disability Adjusted Life Year. And it's a way of trying to correlate and compare different states of health for a person. And that if you're alive for a year in perfect health, then that's one disability adjusted life year. You get one full year of credit for having a year where you're healthy. And maybe if during that year you suffer from COPD with some COPD exacerbations, and maybe you require supplemental oxygen, so it limits where you can go out of your house, maybe that's a half of a disability adjusted life year. And the factors are derived from a number of sources, and they're standardized so that we can make those kinds of comparisons. So what Sherman and Eckelman did in their initial study was they said, okay, well, how many disability adjusted life years do we lose because of particulate matter. And if we're emitting 1 times 10 to the 9th kilograms of PM10 equivalents, then that translates to 435,000 disability adjusted life years, and so on for each of these effects. The ones with dashes are ones that just didn't at the time have good correlations, so they couldn't actually make that comparison. But you can see it adds up to at least initially a large number. So after this study, they went back after some more data were gathered, and they said, okay, well, we can now add in some disability adjusted life years for greenhouse gas emissions. And they based it on these 5 different studies to say, what are the number of disability adjusted life years lost for as a result of climate change. And they kind of did a little bit of a weighted average to add that back in. And here you see this dashed line at the top were the non-greenhouse gas emission disability adjusted life years. So that's these total from that last table right there. It turns out that in the years between that first study by Matt and Jody to the second study by Matt and Jody, there were some shifts in power generation across the US economy. So we actually gained a few disability adjusted life years back, but here they estimate 209,000 additional DALYs lost for climate change, which brings us to almost 680,000 disability adjusted life years lost per year from pollution from healthcare. So this is just for healthcare, the disability adjusted life years that we are causing to be lost in our communities. These are people who are being harmed. And if you want to put that in a little bit of perspective, I was a student when the Institute of Medicine released their 2 Errors Human report that shed a really important light on quality and safety in healthcare and the fact that medical errors were causing people to die unnecessarily. And that caused an uproar. There were hearings in Congress. The Joint Commission jumped on it. Every hospital needed to have a quality and safety committee, and most of them have some senior vice president or higher level person whose job is quality and safety. That was because of an estimated 45 to 98,000 deaths per year. Now, you can't directly compare disability adjusted life years to deaths, but if we just look at mortality, obviously, when you're looking at a disability adjusted life year, somebody who dies, that's 0 disability adjusted life years, so that's a big loss. So let's say on average, the people who suffer and die are losing 10 years of life. Well, that would mean that that this 679,000 is maybe on the order of, let's say, 65,000 mortality. That's right smack in the middle of the National Academy of Medicine report, saying that healthcare quality and safety is causing harm. So my point is basically that healthcare pollution is the same order of magnitude as quality and safety. So if you're putting a whole lot of resources into quality and safety, you should be putting a whole lot of resources into reducing your environmental footprint and helping our communities that way. So hopefully, I mean, I'm sure that everybody was already on board with all that already, but I've just given you some numbers so that when you talk to your colleagues and say, hey, this is important, now you have some data to back it up. So let's talk a little bit about where our emissions come from. In general, when we talk about greenhouse gas emissions, and I'm only going to be talking now about greenhouse gas emissions, but don't forget there are 8 other impact categories that we care about. Those human health, cancer and non-cancer effects, ecotoxicity, eutrophication. Those are all important effects too that ultimately affect human health. But now let's talk about climate change. We talk about 3 scopes of greenhouse gas emissions, 1, 2, and 3. 1 is basically emissions that are directly emitted from our facilities, either on-site combustion, the vehicles that we control ourselves, waste anesthetic gases, refrigerants. Those are the big ones that would come up. And for different facilities, there are going to be different ratios. Scope 2 are basically direct combustion for energy that we purchase. So, I have a house, we get electricity from the grid, we have to buy it because I don't have a power plant in my backyard. And the emissions from that electricity generation would be scope 2 to meet. if I were a power generator, they would be scope 1 to me. But since I'm a hospital, they're scope 2 to me. And then scope 3 is everything else. The biggest ones there are the supply chain, so all the stuff that we use. And then employee commuting, business travel are usually also large factors. It's worth noting that food is a scope 3 emission. And as I mentioned, at least at MGH, we have a huge kitchen serving 30,000 meals a day. That's a lot of food. I just saw it this morning. It's amazingly impressive. And all the emissions from that count in there. So have that in mind, scopes 1, 2, and 3 as we go through the rest here. So now let's see. Let's look at healthcare as a whole. Here we see the emissions of greenhouse gas emissions from healthcare in the world. So this is a global number. The vast majority, well, not the majority, the plurality is energy generation. So electricity, gas, heat, and cooling. Not surprising. They're big buildings. We have to keep them climate controlled. I'm in New England. It gets cold in the winter. It gets hot in the summer. Caitlin's in Wisconsin. It gets colder in the winter and sometimes hotter in the summer. So we all need to make sure that our hospitals are healing places with HVAC running, and we need electricity and things like that. But next, we have a lot in here, the supply chain, 5% just from our electronic equipment. There are a lot of things that we do that generate emissions. So I'm going to aggregate that. Now we're going to drill down. These are world ratios. Let's drill down just to the United States. I don't know if everybody on the call is from the United States, but I suspect at least most of us are. So let's focus on the United States. Also, the United States, by far, we like to say we're number one. We are. We emit the most carbon emissions from healthcare per capita in the world by a lot. So in the United States, 64% of our emissions are scope 3. That's the supply chain stuff. That's traveling. That's commuting. That's a big deal. And 21% scope 1, 15% scope 2. Those ratios, the scope 1 and scope 2, are going to differ based on mostly your energy mix in your facility. But this kind of ratio is pretty consistent in study after study. The UK National Health Service has done a couple of studies on this and have found that their numbers are generally in the 50 to 60-ish% range for scope 3. I think one year it might have been in the 70% range. So pretty consistent. We're in the 50 to 70%, let's say, are scope 3. The challenge is that scope 3 is the hardest to mitigate. So in our facilities, we might like to target scopes 1 and 2 first, just because we can get a bit more bang for the buck initially. It's a lot harder to quantify scope 3. It's a lot harder to change people's practices with regard to the supply chain, but it is possible, and over time we are going to be able to do it. All right, so if you have questions up to here, please put them in the chat. I see very little in the chat so far, but if you want to stop me, you can totally do it. We're going to shift gears a little bit now and talk about sustainability science. So we've laid out kind of the problem that healthcare emissions are a big deal. We're hurting people because of it. It's mostly supply chain, but the other scopes are playing a real material role as well. What can we do about it? And there's a whole field of study called sustainability science that really teaches us about these interactions between the built environment and the natural environment, between our social and natural systems. And we can study it with an eye toward ensuring that we meet the needs of present generations while preserving the ability of future generations to meet their own needs. Basic definition of sustainability. There are lots of tools in sustainability science, and I'm going to touch on a few of them. I don't want you to think that the ones that I touch on are necessarily the best, although I am a little bit partial to the ones that I use. And I don't want you to think that the ones that I touch on are the only way that you can study sustainability and answer some of the questions, because there are lots of ways to do it. And some are easier, some are harder, some take more resources, some take fewer. But there are ways for everybody to find ways to get involved. The first one I'll talk about is, I'll admit, my favorite. It's life cycle assessment. Some of you have heard me talk about it before. It's a great tool that was developed in the 1960s and 1970s to look at a product or a process from cradle to grave, all of the environmental emissions, the impacts from raw material acquisition through manufacturing, production, transportation, use, reuse, reprocessing, and ultimate disposal. It basically, I think of it as the holistic patient view of sustainability science. We would never take care of a patient in the emergency department just looking at their ankle if they're also having troubles with the rest of their body. We need to take care of a whole person to really maximize the goodness that we can provide for them. In the same way, we should be looking at our environmental footprints holistically, because it doesn't make sense to decrease emissions on one side of our operation while increasing emissions even more on another side of our operations. The atmosphere doesn't care which silo is generating the emissions. It just cares that they are in total being emitted. So life cycle assessment is a way to be able to quantify that, to be able to identify the interactions between different factors. The way that it's done is in 4 phases. The first is goal and scope definition. Basically, what are we looking to study and why? How are we drawing our system boundary? The next is a life cycle inventory analysis, where you look at all of the things going in and out of your system to identify what stuff are we making, how are we making it, where's it going, what kind of energy is needed, and so on. And then you translate those inventory numbers into an impact assessment. And that is a way to aggregate so that you get those, for example, 9 impact categories. And I say 9 impact categories because the most common characterization scheme used in North America has 9. But there are other schemes that have 13 or sometimes more, sometimes fewer. The key is that each one gets collapsed into its own unit that you could then make decisions about. Then the last is interpretation analysis, which obviously goes along the whole way as you're working on your study. So let's look a little bit at some life cycle assessments. Here we have the Eckelman and Sherman study on the total environmental impacts of the US healthcare system and the impact on public health. That's where the initial, I think it was 435,000 disability adjusted life years number comes from. And they looked at 11 years of data from 2003 to 2013. You might be thinking, wow, that's a lot of life cycle inventory data. And the answer of how they did it is using a technique called an economic input-output life cycle assessment modeling. It's a mouthful, so we'll just call it EIOLCA for short. And what it uses is, instead of what we'll call a process life cycle assessment, where you would take a product and you might take it apart and you might measure each component, like you might say, okay, this pen has a piece of metal, it's stainless steel, it weighs 1 gram, and it's got some polypropylene plastic, and that weighs 19 grams, and so on, and find out the emissions for each of those. In economic input-output, instead of using mass units, you're using an economic unit. In this case, they use dollars because it's the United States. And they said, okay, well, if we're spending $100,000 on electricity, and we're spending $200,000 on natural gas, and we're spending $1 million on healthcare supplies, and so on, there are interaction tables where you can identify, okay, for each dollar of spending in this particular economic sector, that's associated with this much emission of CO2 equivalents and this much emission of particulate matter, and so on. So they could use these large scale data sets that aggregate a system as large as the US healthcare industry and get numbers. So you can see what the emissions would be this is in megatons of CO2 equivalents for each different category of care over the 11-year period. So for example, hospital care is not surprisingly the biggest. and it went from 184 megatons per year in 2003 to 238 megatons per year in 2013. And then you can add it up and you compare it to the US total, and there's your 9.8% number that we've all been citing day in and day out for the last 5 years since they've done this study. And you can make pretty charts out of it where you basically just take those same data and put it in a chart so that people can see, look, it's going up. And not only is it going up in absolute, it's also going up relative to the US economy. So then you can continue your characterization. And what I'll say is greenhouse gas emissions are what we would call a midpoint assessment. We know that carbon dioxide equivalents go into the atmosphere, but to be honest, none of us actually care about CO2 in the atmosphere. We care about the effect of CO2 in the atmosphere, and we're using CO2 as a measure for that, which is entirely appropriate and clearly indicated and very evidence-based. But when you're talking to a doctor, most doctors, why do I care about CO2? I care about CO2 because I care about my patient's survival and my patient's goodness and how well they're doing. So I can translate these midpoints to an end point of disability-adjusted life years lost. I will admit that if you get into a discussion between physician healthcare sustainability researchers and environmental engineering sustainability researchers, there would be a healthy debate about the validity of making this jump. The data are much, much, much stronger for making the jump from our healthcare practices to CO2 equivalent emissions. Jumping from those emissions to disability adjusted life years lost is good, but not as good. The data are just not as robust there. So we need to recognize that we're throwing some error bars in there that aren't necessarily apparent. So Caitlin's asking what's driving the years with decreases. Let's go back there. And what you'll see is overall, the aggregate number of emissions, the total amount of emissions from healthcare is, at least in this data set, monotonically increasing. There are no decreases per year, but there is an apparent relative decrease from 2009 to 2010, which is, I think, actually more a relative increase in 2009, probably mostly related to economic downturn in 2008, 2009 in the general US economy. So there was a recession, a pretty big recession in 2008, 2009, which depressed economic output in every other sector rather than healthcare. So, if you make fewer cars or you make fewer widgets for people to go to the store and buy, then you're going to emit less stuff from those. So the overall fraction for healthcare is going to go up. In general, you can see that this is a pretty reasonably straight trend. In 2013, you see the healthcare fraction go down a little bit, and that's probably, again, from a little bit more of a US economic boon that all the other industries are going up a little bit. So it looks like healthcare is going down in a relative sense. But good question when you're looking at the data. Okay, so that's economic input-output life cycle assessment. Let's move to a different kind of study. Here we have Andrea McDeal, who's in Canada, did this study looking at carbon footprinting of operating theaters, because she's Canadian. In the rest of North America, we might call them operating rooms. And what she did was she compared 3 different hospitals, Vancouver General Hospital, the University of Minnesota Medical Center, and John Radcliffe Hospital. So one hospital in Canada, one hospital in the United States, one hospital in the United Kingdom, with pretty different operations and different ages of buildings. So for example, John Radcliffe Hospital, not surprisingly, being part of the National Health System, the National Health Service in the United Kingdom is an old hospital. It's been around a long time. The infrastructure is a little bit more dated. And you can see what the different emissions are. The way that she did this was using emissions factors and some waste auditing to say, all right, how much waste are we generating from the ORs? And we can apply some waste emission factors for that. We can calculate the energy requirements for our ORs and use the energy mix for each individual institution. So is it electricity from coal? Is it electricity from natural gas? Are we using natural gas to heat on site? Are we purchasing steam? Those kinds of questions. And you can add it all together. So they have, here are anesthetic gases. Here's HVAC, lighting, and electric loads. Here's waste with emissions factors added in. And here's the total. And what you see is that, that even though the relative fractions of each scope, so for example, at John Radcliffe Hospital, scope 1 emissions are by far the lowest. Their scope 2 emissions are much, much larger. Overall, the totals are, if I look at this, I would say, well, yeah, John Radcliffe Hospital is higher, but you know what? They're kind of all in the same order of magnitude, even though the breakdowns are different. It's worth noting the biggest difference here in scope 1 for John Radcliffe Hospital is anesthetic gases. And it comes down to they do not have any desflurane on formulary at all. They just, you can't use it there. And that's a particularly nasty greenhouse gas among our inhaled anesthetics. So the result is that their isoflurane and sevoflurane emissions are higher than at the other institutions, but it's more than offset by the lack of desflurane. So that's a big deal. So that's how Andrea did this study. It's kind of a hybrid method using data available that are, very evidence-based to be able to get that footprint. So a different kind of sustainability study. Now let's look at a process lifecycle assessment. This one was done by Jody Sherman, Matt Eckelman, and Louis Rublee. And they looked at disposable and reusable laryngoscopes and blades. At many of your facilities, I suspect, you may have recently shifted from reusable laryngoscopes and blades to disposable ones. And Jody really thought that was a terrible idea. It turns out with good reason, and wanted to set out to study it. So here you see her scope. Here's the system boundary. And you have at the top the single-use disposable option. Basically, you make it, you ship it, you use it, and you throw it away. The reusable is more complicated because you make it, you ship it, you use it, but then you have to reprocess it, and that requires heat and hot water and steam, and then ultimately you get rid of it when it's no longer useful. And then Jody also included the costs to say, okay, great, it's not just about the environment, we need to make sure our institutions are financially sustainable. So how much does it cost? So she did this, and here we see the impact assessment scaled. Instead of reporting the absolute numbers, here she scaled it to the lowest alternative. So what you can see is that the single-use disposable stainless steel laryngoscope blade emits 158 times more carcinogenic human health impacts than the multi-use metal blade that is high level disinfected, which is how it needs to be reprocessed. And you can see that in all impact categories, the reusable blade is the lowest. For the handles, the reusable blade with high level disinfection is the lowest in almost every category. Low level disinfection was a little bit better in fossil fuel depletion, but it's only a little bit better. But what we see is that the environmental impacts are hugely different. And in this study, they did one of those process LCAs where they actually took everything apart and they weighed each component and they plugged it into a model and factored in transportation and all those kinds of things, including the reprocessing steps. And you get these nice charts where really the handles and blades are much smaller in the reusable category than in the single-use disposable category. Really big differences. So these are greenhouse gas emissions. Here you can look at the cost. So I said Jody looked at the costs, and lo and behold, turns out the reusable stuff, it's also cheapest. That even when you factor in paying people to do the reprocessing, which is important, and the materials necessary for reprocessing, and the fact that the equipment is more expensive up front because it's more durable, it turns out that it's still less expensive. So you're not really saving much by doing it any other way. Okay, so that takes us out of life cycle assessment. And let's go to another kind of sustainability study. Let's look at waste auditing. People love waste auditing because on the scale of sustainability science, it's interesting, it's obvious, and it's actually not that hard to do. It's a little bit labor intensive, but it doesn't take fancy modeling software. It doesn't take a graduate degree. It's something where you can define your scope and say, all right, we're going to take apart the trash and weigh it and report it. So this is a waste audit from an emergency department. I can tell you now it's actually from the MGH emergency department. We did it not this past summer, but the summer before with a medical student from Brown, Sarah Sue. Some of you might know her. She is a powerhouse. And we did it. We took 24 hours of waste from our emergency department, collected it, sorted it, weighed it, and reported it. And it turns out that in 24 hours, we generated almost a ton of waste, 670 kilograms of waste from one emergency department for one day. And you might be saying, well, it might have been a really busy day. Maybe it was a Monday. Nope, it was Friday. And it turns out that if you plot out our average volume and the average number of patient hours over the course of the year, it was actually pretty darn close to an average day for us. And so you can see that the vast majority of the waste that we produce is municipal solid waste or white bag waste or clear bag waste. We generated still about 10.5% of medical waste and a little bit of recycling. The biggest category was plastic, hard and soft plastic, some of which is recyclable, but really the market for plastic recycling is essentially gone in the United States. And there are lots of reasons for that we could talk about later. But we generate just a boatload of waste. And we can scale that over the course of a year. And we can scale it different ways. All right, let's say we measured for 1 year and we just multiply it by a year, you get 245,000 kilograms or 245 tons. If we divide by the number of patients, we at least in that fiscal year, saw about 113,000 patients, that's 226 tons. And let's say, okay, well, you board a lot, so let's go by patient hours. That's still almost 200 tons. So we're generating between 200 and 250 tons of waste per year. If you want to compare that, the average household in the United States generates 4 pounds of waste per person per day. The average hospital generates 29 pounds of waste per bed per day. And we were generating about 4.5 pounds per ED patient per day. Just like that, it's more than anything else. We're generating a lot. So let's translate that. Let's go to those endpoints and translate it into something that people understand. And it's just the emissions for getting rid of the waste. I'm not even talking about making the stuff, the upstream emissions. I'm just talking about putting the trash in a truck, driving it to the landfill, and letting it sit in the landfill for a couple hundred years. Those emissions are equivalent to driving a car 7,700 miles, which is more than I drive my car in a year. That's just 1 day of ED waste. So there's a lot of room for improvement there. As you can see, it's a simple study. The method is not terribly difficult to understand, yet you can generate really impactful data from it. All right, so there's a little survey of healthcare sustainability science. If you're interested in learning more about sustainability in healthcare and all the different things you can do, I highly recommend this paper. It's called The Green Print. Not surprisingly, Jody Sherman is involved since she's done a lot of the work here, as well as Cassie Thiel. The two of them together are my mentors. And a wonderful team of sustainability scientists, researchers who have done work in healthcare got together for a symposium. It's one of my great regrets is that I was actually on vacation when the symposium happened. So Jody invited me and I couldn't go, but really it was fantastic. And this paper is the result of it. It outlines basically all you need to know to get started in sustainability in healthcare and the research behind it. If you want to think a little bit more narrowly at the emergency department, here are a couple of places you can look. Gail Kuklis from UCSF Fresno wrote this piece in SEM Pulse from our illustrious interest group with just a little bit of assistance from me. So you can definitely look that up. It was in Essay Impulse last month or the month before. And then there's the Climate Smart ED, a primer in Annals of Emergency Medicine earlier this year that we wrote, and gives a little bit of an outline of how you can make changes in your own healthcare environment. So what are some key takeaways? Number one, healthcare generates huge negative externalities. Economists love the term negative externalities in the form of pollution, and that hurts our people. Sustainability science can identify changes that can have marginal environmental benefits, and in aggregate can be very large. 680,000 disability adjusted life years lost per year. And it's actually, that's an underestimate, because there's still those categories for which we don't have the translation from impact categorization to disability adjusted life years. Ultimately, though, larger economy-wide shifts, for example, energy source changes, can have a larger impact. If you change the electricity grid, you're going to change the electricity grid for the hospital and also for all of the upstream producers of our supply chain, which, remember, scope 3 is the biggest factor. And then I'll put in my plug for life cycle assessment, which can enable us to make evidence-based device use, clinical, and procurement decisions where we can compare options holistically, apples to apples, and make good choices that way with our clinical leaders. So with that, I will say thank you. I'm happy to take any questions and talk about whatever it is you'd like to hear about. All right, so Caitlin's asking, can I explain the difference between micro and macro studies in engineer terms? So Caitlin, totally jump in if I'm answering the wrong question here. But when I think of micro versus macro, I think of, for example, economic input-output lifecycle assessment versus process lifecycle assessment. So process lifecycle assessment is really aimed at a relatively small, discrete thing. And it could be hip replacement surgery, the process for getting people hip replacements. It could be, for example, Jody's laryngoscope study. Here are two options that essentially provide the same clinical outcome, and we can compare them on a very micro scale. Whereas a macro scale would be, what is the US healthcare system? Or even, what is a single hospital? What is the environmental footprint of a hospital? And I've been thinking a lot about that because we're about to do it for MGH in the coming year. And it's a really hard question to answer of how do you measure it? There are some pros and cons to economic input-output measurement. The biggest pro is that you can actually do large scale studies. You can take data for a whole economy sector or from a whole institution and plug it into a model without necessarily saying, okay, how many central line kits did we use? What's in a central line kit? What's it made out of? Okay, great. Now let's move on to pneumo boots. What are they made out of? How many do we use? I don't know how many individual components we at the hospital order and use, but it is easily in the six-figure range. There have to be over 100,000 different things that we use in the hospital. It could even be multiple hundreds of thousands of things. So trying to measure all of them and adding them together is just logistically impossible. You can't do it. And you'd spend so much time getting so little benefit. In general, when it comes to environmental engineering, we use the Pareto principle a lot, where for 20% of the effort, you get 80% of the answer. And there's a hugely diminishing return after that. I'll cue you into a little secret. We all drive on bridges all the time. I promise you that the engineers who designed those bridges did not get the design down to the nearest pound per square inch. It didn't happen. I know that because I studied civil engineering, and you just can't do it. So what they do is they throw in risk factors. They say, well, there's some uncertainty here, so we're just gonna multiply everything by 10, and that way we're sure that it's gonna work. And good news, it works. So we can do the same thing in environmental assessment as well, where we say, okay, we're going to put in 20% of the effort, get 80% of the answer, and then act on that, which is very hard for physicians and healthcare researchers to do, because you don't put 20% of the effort into a randomized clinical trial of a drug and get 80% of the answer. You want 100% of the answer. But the reality is that for these large scale studies, it's hard to do that. For the smaller scale studies, you can really drill down a lot more. And we still say that there are some components that are just de minimis. Generally, less than 5% isn't going to change your outcome. So, and you can see that certainly in the laryngoscope study, the differences were so large, and I can go back there, that these differences are so big that even if you're off by 5 or 10%, it's not going to make a difference. So that's kind of the difference between the micro and the macro. You know, a waste audit of the emergency department is micro, and a waste audit of a hospital might be more macro, where you're not going to open up each bag. All right, next question. And Caitlin, totally, if I didn't answer your question, then ask it again. Given the huge environmental footprint of food in hospitals, are you aware of anyone moving towards more sustainable diets in healthcare, i.e. less meat? Short answer, yes, absolutely. This is a big part of Healthcare Without Harm's program, and Practice Green Health is working on it. Every year there are some great competitions for healthcare cooks in hospitals to create a new dish that is plant forward or plant centered, or sometimes 100% plant-based. And it has to be good, it has to be nutritious, it has to be able to be made in a hospital cafeteria. And there are great competitions with awards. I think the ones that are doing more are the usual suspects. So Kaiser Permanente, Cleveland Clinic. Actually, we at MGH are working on a little bit. Some of it has to do with market and what our patients are willing to be happy with, and what our employees and staff and visitors who purchase food in the cafeteria want to see. But we're actually shifting quite a bit more in making our food more sustainable in different ways. And it's not just about less meat, it's also things like antibiotic-free food. The single largest user of antibiotics in the United States is animal agriculture. So you can do things like stop buying antibiotic processed meats. And some of that is a quantity problem. We at MGH have been working for the last year to shift just our chicken purchases to antibiotic-free. And the biggest problem, I kid you not, was not the price, because we were willing to pay for it. It was that no supplier could sell us enough of it every day, until now. So effective January 3rd, we're going to be 100% antibiotic-free in our chicken. And then the next step is moving on to all the other meats, which again is a supply problem. The market is shifting. So there are definitely movements, and I think that our food service staff are in favor of it. One other factor we have to be careful about, though, and it came up in a meeting recently, is equity. That unfortunately the food economy, the food industry in our country is very much set up for calorie-dense processed foods costing a lot less. Fresh produce costs more. And as we shift to plant-centered or plant-based diets, we run the risk of the food that we serve costing more. And we'd want to make sure that all of our people in all of our diverse communities are able to afford it. So I think that there are a lot of factors that need to happen, and a lot of shifts that need to happen at the same time to make it work. So it's not just about environmental sustainability, it's also about equity and inclusion and financial sustainability. So, but there are places that are working on it in food, and obviously it's a big factor in hospitals. All right, Hillary says, my presentation was awesome. You're too kind, Hillary. One, since you're my LCA guru, if you were to do away or replace 3 items in the ED in order to work towards a more green ED, what would they be? And do I know if anyone is looking at PPE waste in the ED during the pandemic? The second question is easier to answer, and that's yes. The reason that I know the answer is because I am doing it. I have a team of a few engineers and a resident and an MPH student who are all looking at a life cycle assessment of personal protective equipment. It's a little bit hard to do because it requires data sharing between manufacturers and reprocessors and vendors and us. And not surprisingly, sometimes they don't want to share all those data, but it is feasible and we are working on it. As far as what the PPE waste looks like, there was just a study out of, I want to say the NHS, the UK NHS, just a couple of weeks ago, where they didn't necessarily break down and do an LCA of the PPE, but they did a basically how much are they purchasing and making the perfectly reasonable assumption that every bit of disposable PPE that they purchase ends up in the trash, because it does. And they quantified that. So I don't remember the exact numbers. Please just look it up and you can find it. So people are looking at it. It was something that came up at a very high level executive meeting at which I was a part last week, where somebody said, "Hey, wait a minute, we're throwing out a lot of PPE," and I said, "Yes, we are, and maybe we should adjust that." And it's worth noting, Robin Gunther is an architect. She does a lot in healthcare and sustainability work, and she has this great line that sustainable healthcare is resilient healthcare. That if you look at our supply chains and the challenges that we're facing during the pandemic, disposable PPE is harder to come by. And if you had reusable PPE and a local reprocessor, like a laundry for gowns, then the chances of you running out of gowns are much lower. And it makes it that much easier for you to operate. The same goes for all the other kinds of PPE. Excuse me. So it's there are more than just environmental benefits to some of these shifts. As far as getting rid of 3 items, I can't answer it with great certainty, but I can say that there have been a good number of life cycle assessments done in healthcare that look at disposable equipment versus reusable equipment. And almost every single one of them shows that the reusable equipment is more environmentally sustainable. And of the studies that have looked at the life cycle costs, every single one of them has shown that the reusable one costs less. So in general, if you're going to target something, find something that you use a lot and is currently disposable and shift it to reusable, whether that's laryngoscopes and the blades and the handles, or PPE, or basins. Lots of these things can be shifted to reusables. There's a particular process lifecycle assessment that, no joke, I have been working on for around 6 years. And it's not done yet, and it really should be done by now because it's not that complicated. And it's the lowly suture kit. You have a patient with a laceration. It turns out that in US emergency departments per year, somewhere on the order of 3 million people have lacerations that need to be repaired. So we use a lot of kits. And when I was a resident, I rotated through 2 main hospitals. One of them had disposable kits. The other one had reusable kits. It made no sense because they were both owned by the same parent organization, but that's the way they operated. And I didn't understand why. So following residency, I'm now on the faculty. I left, I came back, and lo and behold, the place that used to have reusable kits now has disposable kits. So they made that shift. And I really want to be able to quantify the differences so that we can get rid of them. There are challenges there, but essentially almost anything that's disposable can be converted to reusable. All right, now George asks, he also thinks my presentation was awesome. The check is in the mail, George. I'm curious if there has been analysis about the environmental impact about reusable equipment and prions. From what I've gathered, prions are incredibly difficult, which to me translates to energy intensive to kill. Great point. Okay, so the good news is you all learned in medical school, variant Creutzfeldt-Jakob disease is absolutely horrible. It kills everybody who gets it. It's a terrible thing to see. and it's caused by a prion that we can't really kill. And the good news is that it is so amazingly, exceptionally rare. The reality is, and I can check with my central sterilization folks, but the prions are actually killed not by heat. They can't be autoclaved because they're not living things. It's just a protein that folds wrong. They can be killed through chemical disinfection, so things like bleach. So I'm pretty sure that our central sterilization, the high-level disinfection and sterilization process takes care of that, but I would have to check with our central sterilization folk, because I would imagine that we have to have a method for particularly for neurosurgical purposes, and obviously so much of that equipment is reusable already and is processed from the ORs. All right, now Laura asks, is there any work or interest on the relationship between medical futility and the environmental impact of the healthcare system? Oh dear, okay. I'm gonna broaden your question a little bit if you'll indulge me a little, Laura. And I'm gonna broaden your question to be just medical waste. And there are definitely people who are working in the sphere of medical waste defined as care that provides limited or no value. The best example with that would be things like getting imaging on patients with low risk back pain. Is pretty clearly provides no value. So all you get is the risk to the patient and the environmental emissions and the costs without any benefit. And I don't know that anybody has necessarily looked at that from an environmental perspective. I know it's been looked at from a financial cost perspective. The Right Care Alliance, Shannon Brownlee, Vika Saini, have done quite a bit in that realm with looking at patient harm and costs, but I don't think anybody's really quantified the environmental impacts there. So so that might be an interesting angle and area of research if you're interested in doing it. I could maybe ask around if you send me an email. I could see if there are folks who might be willing to work with you on that if you don't have anybody nearby. But it's an interesting angle that I don't think many people have thought about. To be honest, I think that there's enough room for improvement in the care that does provide good value. Although I will say, I had a meeting recently that involved the CEO of our hospital, and after I spoke and people were asking questions about how we could reduce our environmental footprint, the CEO of the hospital basically said to the chief of radiology, you know, one way we could reduce our footprint is by getting fewer unnecessary MRIs, which is totally true. So I think there's plenty of room for reducing our impact in the valuable care and some of the less valued care without necessarily raising a specter of futility. I think that it's almost a third rail to start talking about like, well, we shouldn't do this because it's medically futile and it's environmentally impactful. Those kinds of discussions are really fraught with challenge. All right, I don't see any more questions in the chat, and it is now 59 minutes after the hour. I guess I will turn things back over to Caitlin.
Yes, thank you so much. So everyone, thanks for showing up tonight. Wonderful presentation, excellent information. Just to remind you, join our Climate Change and Health Interest Group and our Wilderness Medicine Interest Group. Spread the word, and the recording will be available starting tomorrow.